Can you all hear me okay?
Yes.
Good morning. Thank you all for being here this morning. Really appreciate you getting up early, fighting traffic. I realized there was trash pickup on 76 and all kinds of fun stuff going on. But we really truly have an all-star lineup here with 4 physicians that are really well known to most of you and are so generous in sharing their wealth of information as well as what they can contribute to as physicians and practitioners who really care for you this morning. Really wanted to thank our national sponsors, and Actelion, Bayer, and Reata, who are our national gold sponsors, as well as just really each and every one of you for being up here early. You all should have gotten a program that has the events for today, as well as on the backside there are events for the foundation going on for the complete year as far as we know it right now. For those of you who don't know me, I'm Fee Sapahi. I'm the executive director of the chapter, and the buck stops with me. So if you're not happy with something, come see me, okay? First and foremost, we're going to have Dr. Reynolds speak about GERD. And if you wouldn't mind coming up here, he assures me that his hair loss is not due to scleroderma, but otherwise he's all things gastroenterology. Right, I was going to mess that up. Sorry.
Thank you very much. Well, good morning. It's a real pleasure for me to have the opportunity to be with you this morning and to talk about gastroenterology and its role in scleroderma. I thought I'd just take a minute because it's probably a little bit odd for your meetings to have a gastroenterologist invited. So I thought I'd take a minute just to tell you what GI is about. As you may know, my subspecialty includes 7 organs of the digestive tract, 2 that are solid and so they don't have motility, and 5 that do have motility. So they're involved with things which move or don't move. As you know, the digestive tract is not only diverse by its organs, but by what it does. Secretion, absorption, metabolism, and what we're going to talk about this morning, motility. Not only that, but there's a very complex interaction between these organs, the 7 organs, and their functions, and the regulatory status that goes on, both the immune regulatory things and the control things. So in my world, we're interested in the control things, the hormones and the neurons that manage the motility of the luminal organs. So you may hear words like motility, gastrointestinal physiology lab, enteric nervous system, smooth muscle disorders, brain-gut interaction, the microbe and how it interacts. And these are things that when you go to GI motility conferences takes up hours and hours, but I won't bore you, but they may be words that you've heard, and they actually impact on your disease and on your normal physiology for your healthy family members. The enteric nervous system, for people like myself who love it, is absolutely fascinating. There's actually more neurons in your digestive tract than there is in the spinal cord. So the brain sends information from the brain to the other organ systems, but there's more nerves trying to regulate your digestive system than there are in your spinal column. They're all the same neurotransmitters that are in your brain or in your gut. In fact, most of the transmitters that are found in your brain were discovered first in your digestive tract. There's constant talk back and forth between your gut and your brain. So unlike your kidneys perhaps, or your lung or other organs where there isn't a talking, we all know that you make me sick, you make me want to throw up, I got the butterflies in my stomach. There's dozens and dozens of phrases we use every day to remind ourselves that our gut is talking to our brain and vice versa, and it has a great deal to do with how you feel and what we can do to make you feel better. And you know that the sensory nerves in your digestive tract are unfortunately very inaccurate. So the challenge of my life is making a diagnosis when the patient really isn't getting much information from their gut about what's wrong. And unfortunately, that goes both ways. Sometimes people tell us they've got a lot of problems and we can't find anything wrong. Other times patients don't feel anything and there's something terribly wrong going on. So the sensory functions of the enteric nervous system are designed to provide very little information to the brain because your brain has more important things to do than wondering what it's up to. But at the same time, that makes a challenge in your diagnosis. Well, let's get on with our topic this morning. You won't be surprised that there's a whole host of immune disorders which affect the digestive tract, and particularly for my topic this morning, the esophagus. And of course, at the top of that list is scleroderma, both systemic sclerosis and CREST syndrome, very frequently, as we'll talk about in a moment, affect the esophagus. But lupus, mixed connective tissue disease, overlap syndrome, paraneoplastic syndromes, dermatomyositis, and polymyositis, pemphigus, and even a new kid on the block, eosinophilic esophagitis, are autoimmune diseases which affect the esophagus and, quite frankly, other organs of the digestive tract, as we'll talk about. Well, how much does it affect the esophagus? Well, actually, 95% of the patients in the room this morning who have scleroderma or the CREST syndrome will have esophageal involvement. And if not managed correctly, will lead to severe complications, such as you can see here in the picture, which includes strictures, which is a narrowing here, precancerous condition known as Barrett's esophagus we'll talk about, and bleeding. And actually, the esophagus is the most common cause of iron deficiency anemia in the upper digestive system, okay? And so it is a serious problem. Gastroesophageal reflux for most patients is belching and indigestion and angina, but for others it can be a very big deal. And obviously in these patients who have esophageal involvement with CREST or scleroderma, or excuse me, systemic sclerosis, Raynaud's is universal. So if you have Raynaud's, you want to be concerned about your esophagus. It's very useful in our expert rheumatologist management of your scleroderma, because sometimes we'll be asked to do a motility test to look at the esophagus to get an inside view of the organ systems within your body to determine whether they're being affected by scleroderma, and it actually often will predate involvement of other organs like the lung. Unfortunately, despite all of these facts, you feel heartburn only 50% of the time. And it goes back to what I was mentioning to you earlier. Your sensory function in your digestive tract is not very accurately giving you feedback about how significant your problems are in your esophagus. Shown on the left is a picture of the X-ray picture of the esophagus. It's widely open. There's free reflux available to go through what should be here a sphincter. You can't see a sphincter here, and so the acid juices from the stomach can flow freely up into the esophagus. Well, I've told you about the immune diseases of the esophagus, and I've told you scleroderma is perhaps the most important one. But what's fascinating is that that happens even though the esophagus is not really an immune organ. In fact, there are very, very few immune cells in the esophagus, and very few of those are actually resident there. They're mostly traveling through. So I've put some of the statistics here and some of the fancy descriptions of it, but the point is that there's actually no active immune cells in the esophagus unless there's damage. So the esophagus, unlike the rest of your digestive tract, which is very, very immunologically active, is not very immunologically active. So we want to ask the question right up front, why is the esophagus involved with an immunologic disorder if it doesn't have a lot of immune cells? And I could spend hours talking about this because I'm very proud of my mentor, Sid Cohen, who over 30 years ago, with many of my colleagues, discovered the fact that the involvement with the esophagus in scleroderma, and probably other digestive organs as well, begins with damage to the neurovascular system. So it's not really an immune effect on the organ itself, it's an immune effect on the nerves to the digestive tract. And as a result of that, there is damage to the muscles. As the muscles atrophy, they are replaced with fibrosis, and this fibrosis then gives the stiff activity in the gut, just as we often see in the skin in scleroderma. So the same process is really an end stage to what began with damage to the nerves. Well, why should you be involved with an interest in the nerves when you really have an immune disorder? Well, quite frankly, the answer is that almost all of the things which affect your upper digestion are influenced by the nerves. Now, I will have to give fair attention to the hormones too, because there are many hormones involved as well. But there's also nerves involved. So the nerves are involved with peristalsis and allowing the food to go from your mouth into your stomach. It's involved with the swallowing. It's involved with making sure there's enough saliva for gravity to wash through. Then there's a sphincter, as I mentioned earlier, between the esophagus and stomach, which must open when you're eating and close when you're not eating. And its closure is what protects you from the acid juices which normally reside in your stomach. Then once the food gets to your stomach, the upper portion of the stomach is supposed to relax to make you accommodate all that food getting in 3 times a day instead of trickling all the time like you would as if you were a smaller animal. And then the lower end of the stomach, called the antrum, grinds the food in a very, very systematic way and makes it so that every bit of food that empties out through the pyloric sphincter, which is a sphincter at the other end of the stomach, is less than 4 millimeters. So less than basically 1/8 of an inch or maybe 3/16 of an inch. So this fascinating grinding function is also controlled by the nerves in your stomach. And then once the food goes out of your stomach into the small intestine, called the duodenum here, there's peristalsis which must occur to push the food further down into your digestive tract where you can absorb it and enjoy the food from a nutritional standpoint. Well, again, all of these are influenced by nerves, and as a result of that, many of the symptoms that you may have experienced, whether you have scleroderma or whether you're a loved one with someone with scleroderma, relate to the fact that these nerves don't work. If the nerves in the mouth don't work, you don't have enough saliva to produce a washing down of the esophagus. When if your fundic tone doesn't relax, you feel early satiety, you feel full with just a small meal. If you don't chew the food up well, if the stomach is not working, you get what's called gastroparesis because it really can't grind the food well enough. If the sphincter isn't working well enough here, as I mentioned, the acid juices can roll back up into the throat and give you the terrible picture that I showed you earlier of bleeding and strictures and pain in the esophagus itself. And the peristalsis isn't strong enough to push that acid juices back down. I mean, normal individuals have acid refluxing into the esophagus all the time during the day, sort of a natural way of protecting the esophagus from germs that might be there. And the peristalsis and the saliva push that down, but again, if they're not working well, it won't get that down effectively. And perhaps most importantly, if your duodenum is not working well, you don't digest your food well, and there's a process known as small intestinal bacterial overgrowth, and where there's germs now that invade the small intestine and compete with your normal digestive process for all of your nutrients, including vitamin B12 and other very important life essential vitamins. So this one slide explains whatever symptoms you may have in your upper digestive tract as a negative impact on the nerves to these very important organs, starting with the mouth, going to the esophagus, the stomach, and then the small intestine. So the good news is that we can diagnose these fairly readily through a variety of techniques, not the least of which is the endoscopy, which I've shown you a couple of times. And we can determine whether the heartburn you're experiencing, the chest discomfort you're experiencing, the regurgitation or feeling of a lump in the throat is a big deal or not a big deal. Because in many patients, certainly most young patients who get these symptoms, there's nothing seen at endoscopy. In fact, 80% of the time, if I do an endoscopy in someone under the age of 30 who has the same symptoms as someone over the age of 60, the endoscopy will be normal. Unfortunately, if it's flipped around and I'm doing the endoscopy in someone over the age of 60, I'm much more likely to find these very ugly findings of bleeding and so forth. So endoscopy is very, very useful to make the diagnosis. And as I'm sure you've experienced, almost all of us have experienced, some kind of antacid-type medication will often get rid of those discomforts, whether it be antacids per se or H2 antagonists or the so-called proton pump inhibitors like omeprazole, we'll talk about in a moment. The problem is that a variety of things can also damage the esophagus other than acid reflux. And the acid just makes it worse. And so it's very important to appreciate, and one of the things I'd like to make sure I communicate to you today is there's other, by the way, very treatable conditions like a yeast infection or a thrush that you may have experienced with your babies when you were moms bringing your babies up that are very common, very easy to treat, that can cause the exact same symptoms as acid reflux. And oh, by the way, this is very treatable. Instead of a lifetime problem with having to take Prilosec, you can treat this with 10 days or 7 days even of an antifungal agent. So I just want to list to you that there are a variety of other problems that can cause a patient to have symptoms that sounds like, feels like, looks like acid reflux. You've taken your acid reflux medicine, you're not quite getting better. You need to appreciate that there are other problems that could cause you to have those similar symptoms. And I want to emphasize pill esophagitis because in an inflammatory disorder like scleroderma, particularly if you have an overlap syndrome or a mixed connective tissue disease where you do have more arthritic problems, the pills that you take often will get stuck in the esophagus because of the peristaltic problem and then cause the same irritation the acid reflux could cause as well. And then there are other problems that you can have we'll talk about in just a minute. So just the point is just endoscopy is a key part of understanding what your problem is, determining the severity of the problem, and designing the treatment to be most effective for you. I do want to mention a couple other tools that we use in neurogastroenterology that are very cool. However, for over 50 years here at the University of Pennsylvania, we've been a leading center for esophageal motility with tracings that look like this. I don't see anyone in the room and the physicians that are old enough to remember this, but this is the way we used to look at esophageal motility with tracings. But now we have what are called high-resolution manometry that is done with pseudocolor, and you can see the peristaltic wave go down. You can see the lower esophageal sphincter open up. You can see the upper esophageal sphincter open up. You can see the fluid being pushed down. So it's a very, very sophisticated technology that now allows us to be more accurate than ever in asking the question, is my esophagus affected by my symptoms or not? And we have other ways of monitoring whether the treatment you are taking is effective or not. Very frequently, you're taking pills to treat the acid reflux and you're still having symptoms. Is it because the motility isn't good? Is it because of some other pill you're taking? Or is it because the acid-inhibiting medications you're taking aren't working effectively enough? So we can measure pH in the esophagus very, very precisely, determine how much pH problem there is, and we can also actually look at reflux episodes that are not all that acidic. That is to say, where food itself is causing you an annoyance that's not actually the acid per se. So more Prilosec, for instance, is not going to help. So anyway, we can do very sophisticated tests to ask the question, how severe the problem is, how big a deal is the problem, and how well is my medicine working? Well, let's go from diagnosis to treatment. What's the best treatment for your acid reflux problem? And for many, many years, you know, it's been a discussion about whether you should take an H2 antagonist, which I've listed here at the bottom, like ranitidine or Zantac, famotidine or Pepcid or cimetidine. The original H2 antagonist manufactured here just a few blocks away in the city of Philadelphia, a world leader in these medications, or the proton pump inhibitors like omeprazole or Prilosec, pantoprazole, or Protonix, esomeprazole, and Nexium, or lansoprazole, Prevacid. So these medications are medicines I'm sure many of you are very familiar with and you take on a regular basis. And the question is, which should I take? And the answer is, how big a problem is your esophageal reflux? Because as you can see by this graph, I want to make 3 points that'll be very clear. Number one, at every time point, the proton pump inhibitors are much more effective than the H2 antagonists. So if you need the big gun, use the big gun. If you don't need it, maybe you won't use that, okay? Number two, that at the end of the day, after 3 months, these are extraordinarily effective medications. There's very few conditions that I treat in gastroenterology where I can tell the patient, I've got a 97% chance that I'm going to make your problem healed up. Okay? So that's all good news. So you want to take one of these medications, you want healing, you will achieve healing in the vast majority of patients eventually. And then finally, even at 2 weeks, the proton pump inhibitors are better in their efficacy at healing than 3 months of treatment with an H2 antagonist. Again, the proton pump inhibitors as a class of drugs are much more effective than the H2 antagonists. So as long as you understand that, they're not interchangeable, but there is use in one and the other at different times in the management of a patient with acid reflux. So few therapies provide greater therapeutic advantage. Proton pump inhibitors for GERD and for other peptic ulcer disease, including gastritis and duodenal ulcers and gastric ulcers. But as you know, no medication is perfect. And in that regard, it's important to ask, why doesn't my pill work? Why doesn't my Prilosec work? I've been taking the Prilosec I buy over the counter. It's so safe. I can buy it in the drugstore without a prescription now. All the medications I've shown you, you can do that with. Why doesn't mine work? And the answer was actually solved many years ago in Germany by Dr. Klinkenberg-Knoll when she asked the question, how much Prilosec do you need to feel well? So she said, what I want you to do is stay on Prilosec. I don't want you to want to go for surgery. I want you to just take whatever you need to take, and we're going to give it to you. We'll give you whatever dose you need to feel better. And she did this for a large group of patients who had erosive esophagitis, like the picture I've been showing you, and they followed them for many years. And what she discovered was that roughly 46% of people require more than the over-the-counter dose of Prilosec. Now, this is everyday people. This isn't people with scleroderma, I dare say. So I would say most patients with scleroderma certainly would need that larger dose. But at some point, you can make virtually everybody happy. So many of my patients, for instance, I'll actually start them on a fairly high dose of Prilosec and then taper down rather than the other way around to make them feel better. But dose is very, very important. You can't just say, I took my Prilosec. Well, what dose of Prilosec did you take? How often did you take it? And it will work 30% better if you take it a half hour before a meal. So you get 30% more bang for your buck if you take it in the correct timing. And there's a complicated reason for that that's very cool, but we'll skip the boring part now. But you say, oh my gosh, I read this article. My Aunt Millie told me, don't take that stuff, it's poison, okay? And through the years, there's always been people throwing rocks at these proton pump inhibitors. For many years, they're the most widely prescribed drug in the world. Now they're the second most widely prescribed class of medications in the world, following the anti-lipid medications. So very, very widely used medications. So you're going to find that writing a paper is very difficult to say something good about a proton pump inhibitor. But if you can come up with any data at all that say these things are a problem, you will get headlines right away. There'll be news people at you, and just like the rest of our world, everybody loves to tear things down. It's much, much harder to build things up. So what are the complications? Well, here's a long list of them. I don't have time to go into them, but what I want to bring to your attention is that small intestinal bacterial overgrowth, which I mentioned to you earlier, and I'll show you some pictures about it in just a moment, is really on the top of this list. Osteoporosis, another very important complication of scleroderma, is at the top of this list, a very important rheumatologic condition. And traveler's diarrhea, C. difficile is on this list too, which you may have had problems with if you've been admitted. So you have to realize that there may be some truth to some of these things. Clearly, the osteoporosis occurs if you're not careful and take a multivitamin every day. Clearly, infectious diseases are more common if you're not careful. There's ways to avoid these things and still enjoy the benefit of proton pump inhibitor. After that, it gets to be a little bit dicey whether it's a big deal, and I would just refer you to your physician to talk about it. The issue of proton pump inhibitors causing kidney damage, the good news about it is it's a very rare condition. It occurs in the people who are elderly, usually in people in their 70s and 80s, and can easily be diagnosed by looking for inflammatory cells in the urine. It's not something that happens to otherwise normal urine and normal kidneys and young people. So these things can occur. I really don't think that there is any likelihood that they call dementia, but I will say that I can't have an office visit with virtually anybody these days that'll ask me about it, and maybe it'll come up in the Q&A later. I hope not. But what about surgery? Okay, gee, I don't want to take those pills, I want to have surgery. And surgery has been shown to be very effective. And Lars Lundell out of Scandinavia led a multi-center trial in Europe to finally answer this question. Well, we asked this question for many, many years. Surgery versus PPIs, PPIs versus surgery. As you can say, at the end of the day, they're pretty much the same. There was no statistical significant difference after 12 years of following hundreds and hundreds of patients in dozens of centers throughout Europe. So laparoscopic surgery is no better than a proton pump inhibitor in symptomatic improvement. The PPI patients did have more symptoms, but at most time points, those symptoms did not reach what we call statistically significant difference. So there was a slight increase in symptoms of one kind or another. I won't bore you with it, but there were a smidge better, as you can see here, but a smidge better with the surgery than it was for the proton pump inhibitors. But you won't be surprised, since this is general surgery, to learn that post-op complications were quite common. The patients in the surgery group are more likely to have a second surgery. Remember, both groups, it's a free world over there as well. They could opt to have surgery or not have surgery. You're more likely to request a second operation if you were in the surgery group than you were if you were taking the proton pump inhibitors. You're more likely to have difficulty swallowing. You're more likely to have gas passing, and so some people have suggested that your spouse should have to sign the consent form as well, and gas bloating occurs. So this is particularly an important issue for our patients with systemic sclerosis and CREST syndrome and other severe forms of esophageal involvement, because if you don't have the push, then creating a valve at the bottom very well make your difficulty swallowing much worse. So I must say, I don't think I've recommended more than a handful of patients in 36 years to surgery for scleroderma involvement of the esophagus, just because I've met so many people who have problems afterwards. So it is a very, very technically challenging surgery. It is not a surgery for your general gastroenterologist. It's a surgery only by the world's experts, which of course we have here at Penn if you need them. And then I will just mention very briefly, just because it's been an area of my research interest for many, many years, that there is actually, as we talk about advancement of cancer, we're sitting here in the Abramson Cancer Center, we're reminded what great successes are being made by cancer. But one thing is very, very fascinating is that a reflux-induced cancer is increasing in epidemic proportions in the Western world. And as I teach my medical students, white men can't jump, and white men get Barrett's esophagus and get esophageal adenocarcinoma at rates which are absolutely extraordinary. It's actually 14 times more common for a Caucasian male to die of adenocarcinoma of the esophagus than it is for an African-American woman. So it's a fascinating research opportunity. We know that it's due to something in the environment. We know there are huge both gender and racial differences. And quite frankly, 30 years later, after having studied this at some wonderful places like the University of Pittsburgh, where I was after I left here at Penn, I went there for a while, and we could not figure out why those things occur. And so stay tuned. But the point is that this is the most severe complication of gastroesophageal reflux disease. And research that Dr. David Katzka, who some of you in the audience may know, and my first fellow and I published, was that it may be increased, particularly in CREST patients, but was not increased in patients with systemic sclerosis. So real quickly, I was asked just to talk about GERD, but my interest is motility, so I can't keep shut about the fact that lower GI tract is also involved with GERD, with systemic sclerosis, and sometimes with the CREST syndrome, you can get gastroparesis. You can get what's called small intestinal dysfunction with pseudoobstruction, maldigestion, malabsorption, and as many personally have experienced, you can get constipation or diarrhea, often diarrhea first and then severe constipation. And you can get what's called paradoxical diarrhea, which is fecal incontinence as a result of severe constipation. And you can also get bleeding a variety of time frames throughout your life due to what are called telangiectasias in the small intestine and stomach. This is what it looks like on an X-ray, severely dilated small intestine with the loops where the scleroderma is actually crunched up the small bowel, making it look shorter, so-called stacked coins appearance. Again, delayed transit, lack of the intestinal housekeeper, which I won't bore you with. But the big issue is it leads to small intestinal bacterial overgrowth. I mentioned before, a very treatable condition that you should be aware of because not all bloating is constipation. Some bloating may be small intestinal bacterial overgrowth. This then can interfere with your absorption, your nutrition, your ability to gain weight, and most importantly, vitamin deficiencies. And again, good news is it's for the most part treatable. Why do you not digest things well? Again, very complicated, but oral intake is very important because of gastroparesis. Most patients with advanced systemic sclerosis need to eat small, frequent meals rather than 3 large meals a day. Bloating is very common, so overcoming that's very important. There's impaired digestion because of impaired mixing, as we talked about, that begins in the stomach and then occurs in the small intestine as well. The pH is a big problem and can interfere with enzyme dysfunction and bile salt deconjugation. There's then problems with absorption, which are relatively sophisticated and perhaps something I won't go through here today, but due to the immune infiltration of the small intestine, which is obviously a very, very intense immune organ with over 25% of its weight being due to immune cells. So the small intestine then takes a big brunt of the systemic sclerosis. It becomes dysfunctional. And so working on nutrition should be a key part of your management of your systemic sclerosis. That's the main point I want to make. Paying attention to your diet, paying attention to when you eat, how often you eat, what kinds of food you eat, while you chew your food, and the vitamins that you take are very, very important in the management of patients with systemic sclerosis. So thank you very much for your attention. I'd like to conclude just by saying that 85 to 95% of all patients with systemic sclerosis or even CREST syndrome will have GI involvement. Esophageal motility is the first and often the most significant of the GI involvement that occurs, but malnutrition is very, very important. and it's something you need to focus on so that you understand that the small intestinal motility and treatment of your symptoms of small intestinal bacterial overgrowth, or SIBO, is something you need to pay attention to. The colonic involvement is very common as well. It's a nuisance, but it's something we can easily treat, and it is a very, what I call, actionable item, which is something I'm always looking for from my patients. And effective treatment is therefore available for most of the GI complications associated with systemic sclerosis. So thank you very much for inviting me to speak this morning.
Dr. Reynolds is going to do his own Q&A because he's got to leave for another meeting. So sorry to kind of put that on you, but if you have any questions for Dr. Reynolds, please feel free to ask them now before we move on.
Yes, ma'am.
I heard recently that long-term usage of like Nexium and Prilosec could be dangerous. Is that something that's true?
So that was a slide I showed that I was hoping you weren't going to ask me about. So these are the complications of long-term use of Nexium and Prilosec and other issues. Absolutely, it causes osteoporosis, and you must take calcium and vitamin D every day. Absolutely, if you go to Mexico for your spring break, you need to be paying attention to that and be more attentive to it than your other family members who don't take Prilosec. Absolutely, when you get admitted to the hospital, you're going to be more susceptible to developing C. difficile colitis. And most importantly, in scleroderma, you're more likely to have small intestinal bacterial overgrowth problems as well. As I mentioned, there's a very, very important paper that has suggested that you can get dementia from taking these medications. But what these doctors do is they look for what's called associations. And this is, I know, very complicated, but it simply asks the question, if you're on Prilosec, are you more likely to have dementia? And that's sort of like asking if you wear a swim trunk, are you more likely to be in Florida? You know, it doesn't necessarily mean that if you have a swim trunk on, you're in Florida, but you're much more likely to be in Florida than you are in 27 degrees in Philadelphia this morning. So the point is just that these are associations, they're not cause and effect. So it's an early finding. Again, I've been doing this since 1986 when Prilosec was first brought out. It's a very difficult thing for you to ask me because obviously I haven't measured my patients for their mental acuity, and we're all afraid as we get to be my age of not being as apt as we used to be. But my own bias is it's a bunch of hooey. Yes, ma'am.
I've heard that we should be taking probiotics on a regular basis, but someone else said to me it's like bringing a teacup to the bathtub.
Well, exactly. So that's a fascinating question, and I'm delighted you brought it up. Your colon has 100 trillion organisms. It's hard to put your head around that, but to give you an idea, it's 100 times more cells than all the rest of your body put together. And these organisms, we used to try and ignore and think they were only bad. We now know that they affect many, many diseases, including diabetes, autism, obesity, and a host of other problems. And the issue is, how do we make them healthy? And so the issue is, well, maybe we should get probiotics. There's a huge multi-billion-dollar market, as you've alluded to take probiotics. The problem is that if you've got 100 trillion organisms and 5,000 types of organisms that are normally in your colon, how does taking 2, 3, or even 10 organisms affect 5,000? And how does a billion organisms that you take by mouth that have to go through the gauntlet of your acid in your stomach and your digestive enzyme in your small intestine ever benefit the 100 trillion in your colon? And that's the point you're speaking of. Is it just a drop in the bucket, so to speak? It's like a drop of water or a cup of water in the ocean. I mean, 100 trillion is hard to put your head around. Having said that, I'm a huge fan of prebiotics. Prebiotics are water-soluble fiber. And your water-soluble fiber can get through your stomach if you make sure it's in small enough particles, and can feed the colon to be healthier. And that's particularly important, again, with patients with CREST and systemic sclerosis because of the SIBO issue. If you have small intestinal bacterial overgrowth, it doesn't make much sense to take bacteria and put them in the small intestine. So it may actually adverse effect, although that's not been well studied yet. But thank you for bringing it up. I think you're right. It's a drop in the bucket, and I don't recommend it. Yes, sir?
You mentioned about diet and nutrition.
Yes, sir.
Do you tailor certain diets to folks who have different types of problems?
Well, we often, again, depends on how advanced your systemic sclerosis is. So many of my patients, who, by the time they come to see me, have gastroparesis, And so we have to put them on a diet where the food particles are easier for the stomach to handle. There are often the nutrients, which are very important because of the SIBO issue. You can't just eat McDonald's. You got to make sure you're eating a very nutritious meal. There's the issue of fiber that this young lady brought up, which is very, very important. And so it's sort of a mixed diet, and that's why, you know, we have a nutritionist, obviously, in the GI department. I don't know, I think rheumatology, you have a nutrition? No. So, I mean, it's an important issue, but it's sort of not a global diet that patients with systemic sclerosis should take. It should be geared to your condition, but I think probably the most important thing is to pay attention to it. Pay attention to your B12 level, pay attention to your weight, and pay attention to your overall nutrition. Yes, ma'am?
When you say water-soluble fiber, is that just regular fiber?
Yeah, so it turns out that, yeah, so the fiber that comes from fruits and vegetables, if ground up well enough, is water-soluble fibers. The fibers that come from bran and from the stems of leafy things like lettuce and kale and so forth are not digestible. Okay, so those are the water-insoluble fibers, and it's the ones like the inside of the apple as opposed to the skin of the apple. So, so we used to push bran a lot, that's the point, and it turns out that bran is not all that helpful. It's the fruits and vegetables related fiber. Yes, ma'am.
So I was told to limit fiber in my diet because of slowness.
Yeah. So that's kind of an old school thing, and I totally disagree with that. Yeah. So because what it is, it's really roughage. So what's difficult for you to get out of your stomach are you know, the broccoli spear. Okay. So if you think of a broccoli, the stem of the broccoli is a rock, right? I mean, what are you going to do with the darn thing? I mean, it's so hard to eat, you know, and you can chew it up and so forth and so on. And when you spit it up, it still looks the same. It's just like the corn, right? The little piece of corn, right? Chew them up, grind them up, they come out like corn, right? We've all seen it. Let's be honest, right? So the deal is that kind of roughage is very difficult for all of our digestive tracts to handle. On the other hand, the top of the broccoli, which is the little flower part, right? That has a lot of the nutrients are in the flower part. So if you like broccoli, chop off the good part and throw away the stem. Okay? So there are a lot of roughage that you have to be careful about, and it's difficult to get out of your stomach. So kale, for instance, would be a no-no if you're trying to eat a kale salad, like maybe your family members might, but take the same kale and throw it in your blender and add some fruits and vegetables, and you've got a yummy diet with all kinds of terrific nutrients. Last question? Yes, ma'am.
Yes, I take Dexalant.
Yes,
I
ma'am.
also take ranitidine.
Yes.
And I watch my diet. I eat 6 meals a day, small meals a day, and I still have breakthrough reflux.
Yep.
And they tell me that I'm on the highest dosages I can be on, and the insurance company won't cover anything but what I'm on. So what's my recourse?
That's probably a long story that may be required more to be in the office, but let me mention a couple things that are faux pas that I see all the time. Number one, if you take ranitidine with your lansoprazole, it actually blocks the benefit of the lansoprazole. So you can't take them at the same time. You can only take the lansoprazole before a meal. So you should take your proton pump inhibitor, your Protonix, Prilosec, Nexium, lansoprazole, 20 minutes before a meal, and then take the H2 antagonist before sleep.
I do.
Okay.
I do. I take the Dexalant in the morning.
So once you've done all of that, then you've got to ask the question, is that dose enough? And I think the way you answer that is by doing the fancy testing I was talking about. Well, thank you very much for inviting me to be here. Thank you. Hope that was useful. Oh my goodness.
If any of you have further questions, please pose them to myself. My business card is out here, and I will connect you with Dr. Reynolds so you can get in touch with him, okay?
Yes, I'd be happy to help if I can.
In the meantime, we've got a valuable orchid here for the coming of spring and a certificate of appreciation.
Wow, thank you very much. That's beautiful.
Last couple of times you've not seen.